Good morning. Thank you very much for coming. So the objectives of today's talk will be to review the use of medical treatment in the management of ureteral calculi, explore the role of early versus late shockwave lithotripsy, management of patients who fail initial lithotripsy, to review data regarding the efficacy of ureteroscopy versus lithotripsy, and there's a lot of new literature published on this, and also to review the contemporary results of the new lithotripter machines, and is the new technology any better? And right up front, I'd like to thank Dr. Chu and Dr. Patterson for helping me put this together. Just a brief introduction, urolithiasis is a chronic disease with substantial economic consequences. The lifetime risk in the United States and Europe is about 5 to 12%, and half of patients are expected to experience repeat colic within 5 years. And the healthcare associated costs are staggering, about $2.1 billion of annual billing claims in the United States alone. We're all familiar with the different management options here. So for the purpose of today's talk, I'd just like to go through each one and present some of the new data and areas of controversy that have been recently published in literature. And hopefully that'll generate some discussion. And we'll start with basically medical expulsive therapy. In 2007, the EUA and the AUA Nephrolithiasis Guideline panel released their updated guidelines on management of ureteral calculi. And they concluded that for small stones less than a centimeter, observation and offering medical expulsive therapy is a reasonable first step. And for larger stones, both ureteroscopy and shockwave lithotripsy are acceptable first-line options. They didn't go with any one of those particular procedures. There haven't been a lot of data on the natural history or spontaneous passage rates of stones. Most of the data comes from 8 small studies presented here. Basically, the weighted averages for stones less than 5 millimeters, about 68% pass spontaneously, and anything larger than that, the spontaneous passage rate is 46%. This was quite a nice study, and it's the largest study on spontaneous passage rates. They looked at 170 patients, and stones between 1 and 4 millimeters had a 78% spontaneous passage rate, 5 to 7, 60%, and that was statistically different than the first one. And anything larger than that, quite a lower rate of spontaneous passage. The same study also showed that location had a significant impact on spontaneous passage rates. The distal stones in the distal ureter and UVJ had a lower likelihood of spontaneous passage. And I don't want to spend too much time on just medical expulsive therapy alone. This is pretty much standard of care now, at least here at VGH. But I just thought it'd be nice to present the paper where the data comes from. This was published in Lancet in 2006, and it was a meta-analysis of 9 RCTs with almost 700 patients. And they looked at trials that compared alpha blockers or calcium channel blockers versus observation alone. And this is just a brief look at their results. You can see their forest plot. The pooled risk ratio for the benefit of medical expulsive therapy was 1.65, and the number needed to treat was 3 to 16, depending on the background rate of spontaneous passage in the control arm. They also concluded that there was no benefit in adding corticosteroids, and that the difference between alpha blockers and calcium channel blockers, that there was no difference. The AUA released their own meta-analysis on medical expulsive therapy. They say that alpha blockers are better than control, about 30%, and that calcium channel blockers have no benefit, and that there's no difference between the different alpha blockers studied. So none of this is new. It's pretty much all review, but there's been a couple of new areas that alpha blockers have been studied for new indications, and I'd like to go over those 2 areas. One is alpha blockers in conjunction with shockwave lithotripsy. So does prescribing alpha blockers improve the outcomes of SWL? And the second area that's had a lot of recent literature published is alpha blockers in the management of stent-related symptoms. We're mostly using anticholinergics now, but there's pretty good evidence to suggest that alpha blockers are more effective, and I'll go over these. So first, alpha blockers and shockwave lithotripsy. This was a recent study in the Gold Journal. It's a randomized trial. They had 186 patients randomized to receive Flomax, steroids and analgesics versus steroids and analgesics alone after shockwave lithotripsy. With a 12-week follow-up, their stone-free rates were significantly different in the Flomax group, about 90% versus 74%. The group on Flomax had significantly less renal colic post-lithotripsy and also required less rehospitalization for pain control. This is another recent study. This one's from Egypt, 150 patients, but this was with renal calculi up to 1.5 centimeters. and they had 3 different groups: a control group, Tamsulosin, and doxazosin. The results were a little bit different. There was no significant difference in stone-free rates after lithotripsy, but the group that was on Flomax had faster mean expulsion time of their stone radiologically, and also postoperatively they experienced less colic episodes and had less analgesic consumption. This is a new meta-analysis published in the British Journal of Urology last year, and it was basically to answer the question, do alpha blockers assist in stone clearance after shockwave lithotripsy? They looked at 7 RCTs of about 480 patients. And again, this was a positive analysis. Their results showed that there was almost a 20% improvement in stone-free rates when adding alpha blockers to shockwave lithotripsy, and the number needed to treat was fairly low. There was also a faster expulsion time with patients on Flomax, and the medication was relatively well tolerated, not many side effects. 2 other meta-analyses have been published recently on the same topic. One compared 3 different alpha blockers and nifedipine to control, and the other compared just tamsulosin to placebo. They were both positive studies, and one of them actually showed that there was less pain and analgesic requirements after shockwave lithotripsy. So, in conclusion, medical expulsive therapy should be offered to all patients observed with ureteral calculi. This is not new, and it's already been practiced. But what is new is that there's strong evidence now to suggest that alpha blockers should actually be prescribed to patients undergoing shockwave lithotripsy, as it's shown to enhance stone-free rates. The next indication that alpha blockers have been recently studied in is stent-related symptoms. A variety of mechanisms have been proposed to explain the pathophysiology of stent-related symptoms. Spasm of the ureteric smooth muscle around the stent, irritation of the trigone from the stent, and the trigone contains alpha-1D receptors. So that's one of the hypotheses of how alpha blockers could potentially alleviate stent-related symptoms. Detrusor muscle spasm around the intramural ureter is another mechanism, hence the use of anticholinergics. And finally, high pressure transmitted to the renal pelvis by refluxing up the stent during voiding is thought to be a mechanism as well. And by relaxing the bladder, neck, and the prostate, alpha blockers are thought to cause or to induce lower pressure voiding and cause less reflux, and therefore less stent pain. Up until recently, there was no validated way to look at stent-related morbidity in patients with ureteral stents until Joshi and colleagues developed the USSQ. It's a ureteral stent symptom questionnaire. They developed and validated this in 300 patients, and this was published in the Journal of Urology. They came up with a questionnaire with 6 different domains that included urinary symptoms, body pain, general health, work performance, sexual symptoms, and additional problems. And since then, pretty much all the studies looking at stent-related morbidity use the USSQ to report their results. A recent study looking at the prevalence of these symptoms in their cohort of patients with stents actually showed fairly high numbers in each domain. About 35% of patients complained of lower urinary tract symptoms, 40% complained of pain, 17% had lower general health scores, and then a lower percentage in the other parameters. The different agents that have been studied in stent-related symptoms are alpha blockers, anticholinergics, a variety of intravesical agents, and drug-eluting stents. I think it's beyond the scope of today's discussion to go through intravesical stents and drug-eluting stents. Sorry, intravesical agents and drug-eluting stents. A lot of that is experimental and not in clinical practice, but there's good evidence for alpha blockers, and I'll briefly go over anticholinergics as well. This is a new meta-analysis published last year in the Journal of Urology, and they looked at 12 RCTs with 900 patients, and the interventions were either tamsulosin, alfuzosin, or both, to treat stent-related symptoms. And the indication for stenting in these studies was variable, ureteroscopy and stones, but also endourological procedures. This is a summary of their forest plot. So they did show beneficial results in favor of tamsulosin, or alpha blockers in general, with urinary symptoms, pain, as well as lower or better general health scores. But there was no difference in terms of sexual symptoms, work-related problems, and the additional problems category. There was also no difference between the different alpha blockers. And in terms of side effects, they were very well tolerated. In the 900 patients in all the studies, nobody stopped the medication due to side effects. Surprisingly, there's actually little data on anticholinergics and stent-related symptoms, despite their more common use clinically for this indication. This was one study published a couple of years ago that compared an alpha blocker to tolterodine and placebo, and again, they showed positive results in terms of lower USSQ scores and IPSS scores with both medications. Several studies have looked at combination therapy of anticholinergics and alpha blockers, but they have conflicting results. Some show a benefit and some don't. So in conclusion, there's good evidence that alpha blockers reduce bothersome stent symptoms, and their prescription and prescribing them to patients who are suffering significant stent symptoms should be strongly considered. It's unclear whether combination therapy is superior, and potentially this could have implications for drug-eluting stents. I know Dr. Chu's group here has looked at ketorolac releasing drug-eluting stents in the Lexington pig model. Potentially alpha blocker releasing stents could be an area that can be explored. So that's all for medical therapy. I think switching gears now, we'll move on to shockwave lithotripsy. And the two areas that have received some recent attention is whether performing emergency lithotripsy is beneficial, so treating patients as soon as they present with renal colic, does that improve stone-free rates? And also, we'll get to that next one later here. So the rationale for emergency lithotripsy comes from animal studies. Several groups have shown that once a stone becomes impacted, ureteral edema develops over the first 24 to 48 hours. And tissue studies have actually demonstrated hyperplastic ureteral mucosa with increased mitoses at about 48 hours in the stone bed. And the edema basically obliterates the stone-liquid interface, and that interface is essential for appropriate delivery of shock waves to the stone. So it's hypothesized that if you perform lithotripsy earlier, or as soon as possible after the patient presents with renal colic, you could potentially have better results. This was a study out of Austria, published several years ago. It was a prospective non-randomized study. They enrolled 94 patients who presented to their institution with acute renal colic, and they basically booked them for shockwave lithotripsy as soon as possible. And the success rate was defined as no residual calculi on a plain X-ray KUB. Their overall stone-free rate was about 77%. The mean time to shockwave lithotripsy was 94 hours. They didn't find a correlation between time to lithotripsy and overall stone-free rates. However, patients that were treated in the first 24 hours required less lithotripsy sessions to become stone-free compared to patients who were treated later on. Also, if patients were treated in the first 24 hours, they cleared their stones radiologically much faster than if they were treated later. And it was quite a significant difference, 6 versus 16 days. This study is a bit more recent. This one is a prospective randomized trial. They looked at 160 patients, and they were randomized to either receive early lithotripsy, so less than 48 hours, or delayed lithotripsy after 48 hours. They were quite aggressive in their treatment in that they imaged patients 24 hours after the first procedure, and if they had residual calculi, they did a second lithotripsy on them, and that's quite aggressive. It's not usually what's done here. Nevertheless, their results were fairly interesting. Again, they didn't show an overall difference in stone-free rates, but patients that were treated earlier, less than 48 hours, required less time to clear their stones radiologically, had lower retreatment rates, and again, required less number of shockwave lithotripsy sessions to clear their stones, and they also required less adjuvant procedures. A significant effect was also seen in patients treated before 5 days, 96 hours, but the effect wasn't as large as being treated before 48 hours. This is quite a nice study in that their kind of model of care is more similar to what we do here. They looked at 50 patients with quite large upper ureteral and UPJ stones, and they randomized them to either shockwave lithotripsy within 30 days of presentation or lithotripsy within the first 2 to 3 days. And their follow-up was imaging 4 weeks after the initial lithotripsy session, which is much more realistic. Again, in terms of overall stone-free rates, they did not find a significant difference between the two groups. But what was different was the patients that were treated earlier, within 2 to 3 days, required less hospitalization for pain control, both before or after the procedure, and they had less outpatient visits, and they also had less number of work days lost due to recovery and pain. So in conclusion, early lithotripsy may be beneficial in terms of reducing pain and morbidity compared with observation or delayed lithotripsy. There is good evidence that if you do the procedure earlier, you'll probably need less treatments to get the patient stone-free. And none of these studies actually use medical expulsive therapy, even though they're recent studies, and that could have potentially improved some of the success rates. The next area I'd like to look at is management of failed lithotripsy. A lot of patients are referred quite frequently for a repeat lithotripsy after they've failed treatment or have had poor response to treatment on the same stone. Now, is this the optimum management? For a repeat procedure to be proposed, basically the success rate has to be acceptable. Now, is that the case for repeat lithotripsy? A couple of studies have looked at this. Seitz and colleagues kind of looked at this indirectly. It was just something else. They were looking at something else in their study, but basically talked about this point as well briefly. 20% of patients in their cohort had 3 and 4 sessions of lithotripsy on the same stone, and in those 3 and 4, in the 3rd and 4th sessions, there was only a 7% improvement in overall success. The main paper on this topic though comes from Dr. Pace's group in Toronto, and that was published in the Journal of Urology in 2000. So it's quite an old study, but it's fairly good. It was a retrospective review. They looked at 1,600 stones that were treated over a 5-year period, and they compared the stone-free rates of the initial treatment versus the retreatment rates. And they also did a multivariate analysis looking at different predictors of stone-free status. They looked at size, location, BMI of the patient, and whether they had a stent placed before lithotripsy. This was obviously a tertiary referral center, and a lot of patients were sent in from community urologists already with an indwelling stent. And they wanted to see if that actually improved stone-free rates or hindered it or didn't make a difference. This is the main table from their paper. You can see their initial success rate was about 68%. Of all the patients who had a second procedure, 46% became stone-free, and patients with 3rd and 4th repeat procedures had a 30% success rate. So those numbers aren't too bad, but when you look at the cumulative total of patients, the number of patients becoming stone-free with each subsequent treatment, that kind of tells a story. So again, 68% initial success rate. An additional 8% of patients overall became stone-free with a second treatment, and then the improvement from the 2nd to 3rd was only 1%, and from 3rd to 4th was only 1%. So really, 3rd and 4th treatments, only 2% of patients overall became stone-free, and those numbers are minuscule. And even considering the second procedure, it was only a 10% improvement in overall success, and that's obviously not a large number. In terms of their multivariate analysis, the top paper shows the relationship of stone size to initial treatment rate and retreatment rates. And basically, the smaller the stone, both the initial and retreatment success rates were higher. In terms of location, stones in the distal ureter had lower success rates, both initially and with retreatment. And I haven't shown the results of their stent analysis, but basically patients who had a stent placed before their lithotripsy were much less likely to be stone-free compared to patients who didn't have a stent. And that's actually been shown in multiple studies, and one of the explanations that I saw was that the stent absorbs shockwave energy, and so less gets delivered to the stone. I'm not sure if that fully explains it, but it's an interesting finding. In terms of explaining the results, it's possible that basically you select out the softer stones with your initial treatment, and whatever's left over is shockwave resistant and not amendable to lithotripsy. In terms of why distal stones had lower success rates, the paper, Dr. Pace's group basically said that sometimes the soft monohydrate stones pass easier down the ureter, and these are harder and more shockwave resistant. So if you're presenting with monohydrate stones distally more often, the success rate for distal stones would be lower. The one criticism of their study is they use a Dornier MFL 5000, which is one of the 2nd generation machines, and a few studies have shown that it's actually quite a poor machine with low success rates, but again, some studies have shown that it's pretty good. So overall, retreatment rates of shockwave lithotripsy retreatment success rates of lithotripsy are quite low, and that patients who fail or have a poor response to their initial treatment should be strongly considered for ureteroscopy, especially if they have high risk features for failing a second treatment, which would be large distal stones. And finally, getting to ureteroscopy. So in '97, the AUA released their first guidelines on management of ureteral calculi, and this was all based on fairly poor quality evidence. Most of it was from retrospective studies, but the recommendations at that time was if you're in the distal ureter, both lithotripsy and ureteroscopy are equivalent. And in the proximal ureter, they actually concluded that lithotripsy was better for smaller stones. This has changed quite a bit, and the 2007 guidelines, again, this was mostly based on retrospective studies. They had very few RCTs to look at, but they did pool results from about 250 articles, and they presented the stone-free rates from ureteroscopy and lithotripsy stratified by location and size. So in the distal ureter, the newer data shows that ureteroscopy probably has a better success rate than shockwave lithotripsy. In the mid-ureter, the success rates were fairly equivalent. And in the proximal ureter, there were similar results to '97. Stones less than a centimeter had higher success rates on average with lithotripsy, and anything larger than that was probably better treated with ureteroscopy. Again, they didn't make any recommendations based on this. This is just what they talked about, but they still said that for stones larger than a centimeter, both lithotripsy and ureteroscopy are acceptable first-line options. And I think that's because they didn't have many randomized trials to look at. This was until last year when the Cochrane collaboration released their meta-analysis on the efficacy of lithotripsy versus ureteroscopy. They only looked at RCTs, and 7 RCTs met their inclusion criteria, about 1,200 patients, most of the stones in the distal ureter. All the studies looked at semi-rigid ureteroscopy, but a variety of lithotripters were used, and the success was defined as being stone-free in 3 months. This is their forest plot for overall stone-free rate, and you can see there's a small benefit in favor of ureteroscopy overall. And in terms of retreatment rate, there's also a benefit for ureteroscopy overall. The areas that did favor shockwave lithotripsy were adjuvant procedures, complications, and recovery time. So patients with lithotripsy had significantly less complications and tend to recover faster than ureteroscopy patients. They didn't make any conclusions on post-procedural symptoms, the efficiency quotient of the procedure, or patient satisfaction. The efficiency quotient is just a measure that takes into account the initial success rate, the retreatment rate, and adjuvant procedures. And they also said that there was no significant difference in terms of stone size, and that sort of that 10 millimeter cutoff in the proximal ureter was no longer true, and that basically ureteroscopy is better for stones of any size. This is the most updated data on this. It's going to be published next month in the Journal of Urology. The article is still in press. It's from James Lingeman's group in Indiana, and they did a meta-analysis as well, looking at 9 RCTs, almost 1,400 patients. And they divided their analysis again into proximal distal stones, similar to the AUA guidelines. And they also looked at whether there was a difference between the original HM3 lithotripter versus the newer generation lithotripters, and if that made a difference in terms of success rates. For distal stones, they concluded that ureteroscopy was 55% better than the newer non-HM3 lithotripters, and there was a 7-fold less retreatment rates with ureteroscopy. And based on one study, they said that there was no difference between the original HM3 and ureteroscopy. And there's actually quite a few studies that show that the newer generation machines are not as good as the old ones. There were more adjuvant procedures with ureteroscopy and no difference in complication rates overall in the distal ureter. In the proximal ureter, ureteroscopy was better than shockwave lithotripsy with lower retreatment rates, but based on one study, they said there were more complications associated with flexible ureteroscopy in the proximal ureter. So that's what the data shows. What are people doing? These 2 studies surveyed urologists in the US and Canada. The first one, they surveyed about 800 members of the North Central section of the AUA with 170 respondents. And the second study is from Dr. Pace's group from Toronto again. They surveyed 130 members of the CUA, and this was published in the CUAJ last year. And most of the respondents actively treated stone disease. I've kind of presented the results from both studies here on the same graph. This is for distal ureteral calculi, and the purple bars represent ureteroscopy. And it's quite obvious that for distal stones, most urologists in Canada and the US prefer to do semi-rigid ureteroscopy, and this is what the data shows and what most of the guidelines are suggesting. In the proximal ureter, it's a little bit different. The blue bars, or the green bars, represent lithotripsy, and you can see that even for larger stones, even up to 10 to 20 millimeters, a significant portion are recommending lithotripsy, up to 40 or 50%. And this isn't just ideal. This isn't what they think is more feasible at their institution. This was what they thought was the ideal treatment for these stones. So, in conclusion, ureteroscopy is definitely better for distal stones, and that was true in the old guidelines, and that's what the new data shows as well. And that's likely because of ease of access to the distal ureter with semi-rigid ureteroscopes and the poor results of shockwave lithotripsy for distal calculi. For the proximal ureter, the updated data shows that ureteroscopy is always better. This is likely due to improvement in flexible scopes, lasers, baskets, etc., and also the lower success rate of the newer lithotripters. But shockwave lithotripsy is still quite prevalent for even large proximal stones in urologic practice. Should we be performing ureteroscopy on all patients with proximal stones? Well, that's not very feasible, and you have to kind of take resource availability into consideration. But I think patient selection is important. So that kind of mentality of doing shockwave lithotripsy first, and if that fails, moving on to ureteroscopy may not be the most cost-effective method. I think patients that have high-risk features for failing lithotripsy, so large stones, distal stones, obese patients that have been shown in studies to have lower success rates, high stone density on CTKUB is also associated with lower lithotripsy rates. I think those patients should be considered for ureteroscopy right up front rather than be offered a procedure that could potentially have low success rates. And just to conclude, I'd like to talk about the evolution of lithotripters. I've mentioned a few times that the newer technology may not be as good as the old one, and we'll go over the data. And sorry if I offended anyone who drives a Prius. The original Dornier machine was developed in the 1980s. The first human was treated in 1980, and FDA approval was granted in 84. The historical stone-free rate with the original machine was 77 to 90%. Most studies were, however, in the high 80s and the low 90s. The major drawbacks were a large size, the need for a water bath, and the need for a general anesthetic. Since the original machine, about 40 different lithotripters have come on the market. The new technologies focus on making them smaller and more portable, eliminating the water bath, and also eliminating the need for a general anesthetic. The main difference in technology between the old and the new machines is the different shockwave generators. So the original machine had a spark gap, or an electrohydraulic generator, and that was basically a spark gap immersed in the water bath that generated the spherical shock waves that were then focused onto a focal point in the kidney called F2 with a reflector. The newer machines have an electromagnetic coil which generates linear shock waves, and that gets focused onto the kidney, onto that F2 focal point by an acoustic lens. And that eliminates the need for a water bath because you can just have that electromagnetic coil surrounded by a small chamber of water. In terms of reducing the need for general anesthetic, the newer machines have a wider aperture on the shockwave generator, and what that does, it spreads out the acoustic energy over a wider skin area, decreasing the shockwave density to a particular skin area, and therefore reducing pain and eliminating the need for general anesthetic. That comes at a price, however. The wider aperture creates a smaller focal zone, so that F2 point on the kidney becomes smaller, and that's thought to be the reason that the newer machines have a lower success rate compared with the old ones. The picture on the left shows the focal point of the different machines, both in long axis and short axis. The original HM3 focal point is at the very top, and you can see the Stort's focal point, which is right in the middle, and that's a new machine that we're using now. Is quite smaller than the original HM3 lithotripter, and that's thought to contribute to some of the lower success rates. Also, the small focal zone of high energy is postulated to cause more tissue injuries, and some studies looking at hematomas post-lithotripsy show that with the newer machines with the smaller focal zones, that's a higher risk factor for getting perinephric hematomas. So have these design modifications made a difference? Well, the new machines are more mobile with less analgesic requirements. Here we use conscious sedation, but at a lot of centers, conscious sedation is not even required for lithotripsy. And like I said, there's a lot of data that suggests that the second and third generation machines are inferior to the original Dornier. Just a little UBC connection here. This was one of the first large prospective randomized trials comparing two different lithotripters. It was published in '95 in the Journal of Urology from Dr. Sullivan's group, and they compared the modified HM3 with the MFL 5000, and that was one of the first studies that looked at two different lithotripters. So like I said, there have been few studies looking at lower success rates of the newer machines. The study at the top there was one of the big landmark trials from '92. It was a multi-centered randomized trial, and they looked at the success rate of second-generation machines. And the results were actually quite dismal, only a 45% stone-free rate and up to a 20% retreatment rate. With the third-generation lithotripters, a lot of studies have been published on this as well, and the results are more variable, kind of 40 to 80% stone-free rate and up to 40% retreatment rate. We've now moved on to the fourth generation machines, which is the one we have here, the Storz Modulith SLX F2. And the advantage of this particular one is that it has two different focal points. Remember how we talked about the smaller focal point with the newer machines? The Storz has actually two. You can use a narrow focal point or a wide focal point. But even the wider one is still smaller than the original HM3 focal point. And in several in vitro studies, this has actually been shown to have better stone fragmentation than even the original lithotripter, the HM3. But does this translate into clinical success? This is a fairly recent study from Urs Studer's group in Switzerland, and they did a prospective randomized trial looking at the SLX F2 and the modified HM3. They had 820 patients, and they exclusively used the wide focus feature. And their results showed significantly better stone-free rates with the HM3, but the Storz still had fairly good success rate at 81%. The retreatment rates were similar. And in terms of secondary treatments, the Storz required more, and most of those were ureteral stent insertions. The efficiency quotient of both were quite high. This was a recent study from Montreal, and this was a retrospective review. They looked at 550 patients, and they exclusively used the narrow focus of the F2 lithotripter. And their results were fairly similar, the stone-free rate of about 81%, retreatment rate of 14%, but a lower efficiency quotient. They also did a multivariate analysis looking at possible predictors of stone-free status on the new F2 machine. And younger age, smaller stones, again, the absence of a stent, and for unclear reasons, right side were thought to be associated with higher stone-free rates. So is the wide or the narrow focus any different? Does that actually make a difference in the efficacy of the new machine? There's a clinical trial that's recruiting right now. It's based out of Toronto, but we're participating, and multiple centers across Canada are participating as well. And it's basically a randomized trial looking at the narrow versus the wide focus of the new lithotripter. So in conclusion, although there aren't a lot of trials looking at the success rate of the fourth generation machines, there's good data that suggests that they have fairly good success rate, maybe not as good as the original HM3, but definitely better than the second and third generation machines. I think the success rate we should be quoting patients is about 80%. The advantage of the dual focus system is not clear, and the randomized trial is pending. And again, I think given the results, given the data that shows the superiority of ureteroscopy and lower success rates with the newer machines, I think patient emphasis is again important. So patients with larger stones, obese patients, patients with large skin to stone distance, distal stones, and also patients that have failed previous lithotripsy for the same stone should be strongly considered for ureteroscopy right up front rather than shockwave lithotripsy. Thank you very much.